Welcome to Brain Attack series. Today's episode is about coma stimulation. And my name is Ganapathy. I am the head of the occupational therapy department and also advanced neuro rehab specialist. Coma is otherwise called loss of consciousness. Means what is consciousness that we have to understand first. Consciousness happens in the brain when all the sensory input which comes towards your body, you should be able to pay attention and understand it. Through your perception, you have to understand what is happening in your surrounding. In a simple word, it is about the awareness of your environment or surrounding. Now, when you have a head injury or a stroke or head injury, what happens is the brain is sitting in a compact skull where you don't have any other space. So, when you have a extra accumulation of blood or extra fluid collection in the brain or injury which causes inflammation of the brain, which compresses the brain, both the sides brain, then people will not receive the sensory input towards their cortex, which is the outermost area of the brain, which causes coma. Now, in the medical field, how they assess coma is they use three parameters. One is eye opening, second one is the verbal response, and the third one is the motor response. So, when you say eye opening, how they are opening their eyes? Like, are they opening their eyes with just name call or towards pain, or spontaneously by themselves they are opening their eyes? Based on that, that is graded. The second thing is, how is their verbal response? Are they making sound, or if they are talking, are they talking clearly, are they communicating better? Based on that, their verbal responses are graded. And the third thing is the motor response. Motor response is like there may not be any motor response even if you give a painful stimuli in the extremities, in the sense hand or leg. If you give a painful stimuli, they may not respond. And in some cases, like if you give a stimulus, they may bend their leg, abnormally bend their leg, or they withdraw from the pain, or if you tell them like move your hand, show your tongue, they obey the command and do it voluntarily. Based on their level of response, it is graded in multiple grades, 1, 2, 3, like that it is graded. Now, which is called GCS, Glasgow Coma Scale. That is a standard scale which is used in the medical field. In rehab side, we use something called Rancho Los Amigos scale, which is cognition based. In that, first 4 levels are loss of consciousness to coming to consciousness just before getting awareness. In the sense, the first stage is called no response. It means whatever stimulus which is coming, it can be pain, it can be touch, it can be sound, you are calling them, or any kind of stimulus which is coming towards their body or towards their brain, they will not give any response at all. The second response is called generalized response. Generalized response in the sense, you may give a stimulus towards the chest or above the eyebrow, or you give at the periphery of that means the fingers or your leg, you give some painful stimulus, but they may not withdraw that, or they may not localize and touch that area and remove the stimulus, but they will show some facial expression which is more generalized, but they are appreciating the pain or stimulus which is coming from outside. The third thing is called localized response. Localized response means the brain knows where the pain is happening, and the hand will come towards that stimulus, trying to understand where the stimulus is coming from, and they withdraw that stimulus. This is called localized response. In third stage, in the fourth stage, there is an important stage called agitated stage, where most of the family members worried that a patient behave more aggressively, or they pull out their Ryle's tube and they may spit, they may kick, they may get up out of the bed and then roam, move around. So this is most anxious stage for the patient, because they may think the patient get some psychiatric problem because of the head injury. But we say that this is the brain which is getting more stimulation. The brain is not able to tolerate that much stimulation, though it behave more abnormally. After that, what happens, this agitation or anger reduces, they become going into a confused state of orientation, understanding what is happening around them. And from there another 5 steps are there. Totally it has 10 stages. When they come to the 10th stage, they will be almost normal like you and me. So what is coma stimulation? Coma stimulation is, we use 5 different senses. You know all 5 different senses, like your visual sense, olfactory or smell sense, taste sense and touch sense and hearing sense. These are the 5 senses. We have another 2 senses which are called hidden senses, which normal people, lay people may not be aware of it. That is the sense which is coming from your joint, and the sense which is coming from your inner ear, which will tell what is your head position, which direction you are moving. These 2 senses are very, very important for you be more alert. That is why when you are doing exercise or walking, you feel more aware and alert. So now these 7 senses we have to stimulate in more systematic way for a coma stimulation. For an example, in many scientific researchers says that when you do not stimulate the brain for a long enough, or if you are in an environment where none of these sensations are coming, your brain can go for sensory deprivation, and slowly the brain will become weaker or atrophied, or it will become smaller in size. They will not be able to perceive that senses later. So we have to, when the patient is in coma, we have to stimulate the brain, first thing. Second thing is, you have receptors in all these sensory organs, like for example tongue, you have small taste buds which will receive the sensation and send it to brain, or you have in retina, you have receptors which will receive the sensation and send it to. Even though your brain is affected, when you are receiving these senses, the sensory apparatus, this is like a small device which should not go for wasting. So that is also one of the main reason why we do early coma stimulation, which will recover the patient much faster than without stimulation. In PRS neuroscience, we use a very systematic approach doing coma stimulation. So we consider 2 things. One is giving a very basic fundamental stimulation in a periodic manner through patient caregiver or close family members. For example, your stimulus which you are receiving is always close to your heart. In the sense, if I am going and talking to a coma patient, they may not respond as better as when the family member talk, because the family member sound or their presence is already familiar and it is in their brain. So we are using these 2 approaches. One is a non-structural systematic coma stimulation, where we introduce one stimulus at a time. For example, for vision, photon, that is the light is the main stimulus. So we use different intensity lights to stimulate their visual circuit in a more safe environment. And second thing is the auditory, we use different sounds which will stimulate the auditory senses, like that the taste sense and olfactory sense, that is smell sense. All these things we will systematically do it in a more periodic way. The most important thing is we should not stimulate the brain continuously, otherwise it will go for shutdown. It is called brain shutdown, because it will get bored and it will shut down, it will not respond. So it has to be done in a more systematic and periodic manner. The second thing is we have to put them in more familiar environments, like familiar in the sense what is their routine, like what they used to do before getting into coma, like before they got coma or head injury or whatever it is. So we understand that, analyze it, and we have to recreate that kind of environment for them to get better. So some of our patients show much better improvement when they are in their close family surrounded by, when they are talking, when they are showing their videos, when they are making video call and talk to their children. So they respond much better because it is because of their familiarity towards that stimulus. That is how we stimulate in PRS neuroscience when the patients have coma problem. So this is regarding a patient I have seen about 10 years ago. This patient was admitted in one of a corporate hospital in Bangalore, and the ICU doctors were telling he got a head injury, road traffic accident. He had a massive head injury, and then he got admitted in the ICU, and the ICU doctors were telling that this patient may not recover. And it's not about like good or bad about it, but what I think is we have to try everything possible to get the patient back to their normalcy. So we started early coma stimulation. I think I have almost used anything which can stimulate him. We have used visual stimulations and videos, which is like basically basic lights we have used, and we have used things which he likes, like cigarettes we have used, and we have used different kind of perfume which he was using, and tactile stimulations, and we put him on a wheelchair, and we move around in the familiar environment so that he can get these kind of stimulus again and again. It took almost 1 year, a little less than 1 year for him to just come out of coma. But after 2-3 years, the patient become almost walking with a walker, and the family is really happy because he is a young boy, only son. The family is very happy that he got back to walking with a walker, and his communication and his understanding and cognition, everything was good except minimum memory loss. So what I understood from this thing is we can predict the improvement much earlier in a more positive way than a negative way. So we can give only hope to the patients so that they can try their maximum to achieve the best result for the patients. Thank you.